For us, please, Mr. Caldwell. Thank you very much. Welcome, ladies and gentlemen. This is the Labor, Health, Social Services Committee, February 19th. I'll make a couple first opening comments. We are missing 3 members. And so while we don't have a quorum for taking action, we can take testimony. That testimony, of course, is available online. I will encourage our colleagues that aren't here to review that. And if no one returns, i.e. we don't have a quorum prior to the end of the testimony and the presentation of the bill, then we'll continue this over to Friday for that consideration. So Representative Singh, I apologize. It's inconvenient for you, I know, but I can't change those folks that have other obligations. And so if you would, Representative Singh, so anyway, at the current time, Representative Crum, Scott, and Steinmetz are excused. Present are, excuse me, I said senators, Senator Hutchings and myself are here. So Representative Singh, if you would take us through House Bill 121 engrossed. Thank you.
Thank you, Mr. Chairman and members of the committee. My name is Daniel Singh. I represent House District 61 right here in Cheyenne, Wyoming. And I'm bringing House Bill 121 engrossed to you today. It's hospital pricing transparency. And I think this bill, its aim is pretty straightforward. But at the end of the day, it is for the people of Wyoming, for the customers. At the end of the day, who are ultimately affected the most by this. And so just going through the bill page by page here. So section 1, it's talking about the short title here. It's the Hospital Price Transparency Act. And so we start with the definitions in 35-2, 1502 on page 2, line 14. And just going through some of the important definitions that are highlighted here on page 3, starting at line 2, you have your de-identified maximum negotiated charge, which means the highest charge for a facility that has negotiated with all third-party payers for a facility item or service. And then on line 6, you have the de-identified minimum negotiated charge, which means the lowest charge a facility has negotiated with all third-party payers for a facility item or service. And I just mentioned that because that is an important aspect of the menu that we will be discussing later. So just moving along into the rest of the bill on page 4, it needs to be available, starting at line 12, any other form or service which a facility has established a standard charge. They need to have a gross charge, which means a charge for a facility item or a service that is reflected on a facility's list, less any discounts. It needs to be available in a machine-readable format and a payer-specific negotiated charge, which means that the charge that a facility has negotiated with a third-party payer for a facility item or service. The standard charge on page 5, starting at line 8, it includes the gross charge, the payer-specific negotiated charge, the de-identified minimum negotiated charge, de-identified maximum, and a discounted cash price. Going on to page 6, line 9, it talks about the availability of this information, that a facility shall make public a digital file in a machine-readable format that contains a list of all standard charges expressed in dollar amounts. So that's important, in dollar amounts for all facility items or services as described by Wyoming Statute 35-2, 1504, a consumer-friendly list of shoppable services. And starting on page 7, the beginning of page 7 on line 1, it goes through a list of all the standard charges required.
Would you, Representative Singh, would you take questions as you go?
Sure.
Just further, I know there's only 2 of us, but could you actually explain or give me a little more definite or a little more context of what a shoppable service is? I see the definition, says scheduled in advance. And then I see this is part of, it's on page 5, lines 5 and 6. That's the definition. Scheduled in advance. So this is not a prescribed procedure or something a doctor orders. It's something that, I just want to make sure, I just understand what the context is. It's something that a physician or a medical professional is or telling the patient to do, or is this something they're doing on their own? Representative Singh.
Thank you, Mr. Chairman. So this would apply to any of those services which could be prescribed, but also may be independently planned in advance.
Thank you. Please proceed. Please proceed.
Please
You were
proceed.
on line,
Thank you, Mr.
page 7,
Chairman.
I think.
Yes, on page 7, line 1, it goes through the requirements of facilities, that they maintain a list of all standard charges for facility items or services, and according to this section, that the list is available at all times to the public, and that this list is actively maintained by the facility. And then the different requirements would be some of those definitions that I was talking about earlier on page 8, line 8, the de-identified minimum negotiated charge, the de-identified maximum negotiated charge, and the discounted cash price. All of those would be made available by the facility. It shall be, on page 9, the list required under subsection A of this subsection shall be available free of charge without having to establish a user account or password, without having to submit personal information, and without having to enter a code to access the list. So this list that is available for the services that are at the hospital is very easily accessible to the public in a way that's not shrouded at all.
Could I ask another question? I'm sorry, this goes back to page 8. This is the description of facility item provided, and then Romanet 2, page 4, line 4, talks about the following charge expressed, and it goes gross, de-identified, max, min, and discounted. But when we go back to standard charge, it also includes payer-specific charge by the definition. So this seems to be different than the standard, which is referenced in, anyway, I'm just trying to understand. There's a different list here than there is in the definition. Is that on purpose, or is that not? Thank you.
Mr. Speaker, or Mr. Chairman.
Oh,
Mr.
it's actually
Speaker,
down
yeah.
below. Never mind. I see that. It's just different order, different, yeah, my apologies.
Thank you, Mr. Chairman. Where was I? Well, if that answers your question, so
Yeah,
on.
I got it. It did. 'Cause
Okay,
It was just
thank
out
you.
of order, and I was looking for the same order. So please continue.
All righty. Thank you, Mr. Chairman. So going back to page 10, it needs to be, so we're talking about this list that is available from the facility. It's accessible to a common commercial operator of an internet search engine, so you'll be able to easily find this online in a manner prescribed by the department, digitally searchable, using the naming convention specified by the Centers of Medicare and Medicaid Services. It shall develop a template using the formatting of the list. And so there are a lot of different services that'll be on this list, which mirrors the federal policy that we have in place already. And so because of that, it's not an insurmountable task.
Okay, all right. I think we have a question from Senator Hutchings.
Thank you, Mr. Chairman. Representative Singh, I'm envisioning, I go online and I go to the hospital website and I click, okay, costs. I'll see a list. I'm gonna have a knee surgery, so I'm gonna be paying for gauze, this gonna cost this much. They may give me wipes, they may give me this, stitches, blah, blah, blah. I'm seeing that and the price for each on the website. Am I envisioning this right?
Representative Singh.
Mr. Chairman, Representative Hutchings, yes, that is correct.
Okay.
Thank you. Please proceed.
Thank you, Mr. Chairman. And so the next section on page 12, it just goes through the list of shoppable services that is required. And that continues through page 13 and 14. And 14 really goes into, again, the availability of the procedures involved, that this information is free of charge without having to register or establish a user account or password, without having to submit personal information or a code to access the list, that it's searchable by the service description, the billing code, or the third-party payer, so the different insurance providers. It will be, then moving on to page 15, that there is a reporting requirement to the Department of Health, that it will be going into the next statute change here on page 9, or on line 19. The department shall monitor each facility's compliance with it, with this new requirement, that complaints are evaluated and things of that nature. And then on page 17, it goes into what happens if a facility is not meeting this requirement, that they don't comply with these new statutes, that they don't publicize this information. You can see on page 18 that it walks through the plan to submit a corrective action in the form of this matter, act to comply with the plan within 30 days of submitting, describe in detail the corrective action, provide a date by which the facility will complete this corrective action. And on page 19, or starting on page 19, going into page 20, it talks about the actual material consequences would be for violating this for facilities categorized as critical access hospitals with less than 200 beds available. This was an amendment that we added in the House. It differentiates between the larger facilities and the smaller facilities, which are experiencing they are experiencing financial hardships. And so I don't want to somehow cause a critical failure while pursuing what I believe is justice here. But so for the first offense for the smaller facilities, it is $100 per day that a facility fails to comply with the subsection. The second offense, starting at line 17 on page 20, is $500 a day. And then on line 22, the last line there, it's $1,000 a day. And then for all other facilities, the big facilities, $1,000 a day, a facility fails to comply with this subsection. And then on page 21, there are legislative findings. The department shall propose to the legislature any necessary recommendations for amending this act, including recommendations in response to amendments by the Centers for Medicare and Medicaid Services. And then the last, this next section here, starting on page 22, it prohibits collective action or the collection of debt from facilities that are out of compliance with this new policy. And so this is truly to ensure that when folks are put into debt, that they at least have the tools available to them to be able to establish what it is that they're paying for. And all that can be explored in pages 23 through 27. Yeah, the end of 26. And so that, in essence, is the bill. It is a long bill, but it is a pretty straightforward bill with its intention here. So with that, I do have someone that I'd like to have give you some testimony on how this has worked in other states. And with that, I stand for any questions.
Okay, thank you. Do you have questions? Senator Hutchings.
Thank you, Mr. Chairman. Representative Singh, I like what you're doing, and I think you know that. But I have one question. If we go to page 28, lines 2, I think this is a big ask for July. It goes into effect in July. Has there been any pushback as to when the department or the hospitals can have this done? Is there software out there that you know of that they could purchase and get this taken care of right away? If you can answer that.
Representative Singh.
Thank you, Mr. Chairman. Senator Hutchings. So we did have some conversations about when this would be implemented in the House. Some folks wanted to see it sooner than later. Some folks wanted to see it happen later, extended it by a year. Because this does have parallels to existing federal policy, we decided not to move the date at all, as it was kind of, it would seem redundant if there are hospitals that are already following this type of policy to change that date.
Okay. Thank you, sir.
Thank you, Representative Singh. So on that note, what is the federal policy and how close is it, or how much different is it than what's in this bill?
Thank you, Mr. Chairman. And I might actually phone a friend at this point to come up and help explain how this relates to federal policy. But this was initially introduced under the 45th president. This, as a federal policy, was introduced. But with the following president, we saw that it was severely weakened from the standpoints of consumers. And with the new administration, though we don't know exactly what's going to happen, we can protect our citizens by adopting this policy.
So what is 45 CFR Part 180? It's your bill, you reference it in it. What does it do? It's referenced specifically on page 12, line 13, 14, about the 70 services. These are the shoppable services. There's actually CMS referenced several other places. So naming convention used by CMS. So what is the current status of, and other folks will get a chance to provide testimony, but I guess your understanding as a sponsor bill, what is already being done? Not what somebody did or didn't do, what is currently available?
Sure. Thank you, Mr. Chairman. And so the current policy, it does not include dollars and cents. That is the key difference with this bill. And so while there are various levels of compliance with the federal policy, having availability of the de-identified negotiated minimums and maximums, this information isn't available in the same way that this bill is requesting to change right now. And so
So
having
the standard charge by definition, the standard charge by definition is gross charge, negotiated, de-identified minimum, max, and cash. That is currently not part of the, if I understand you, of the CMS current approach. Is that accurate?
yes.
And the rest of it would be a part of it? All the charge, the shoppable versus et cetera, that is required?
That would be what this bill is.
No, current federal policy.
That is
Current
not.
federal policy, are those things part of what's reported or not?
No, that is not.
Okay, further questions, Senator Hutchings, go ahead.
Thank you, Mr. Chairman. Going to page 20, I'm concerned about the fines. What have you seen pushing this through about these fines? I see they're still there, so that means no one amended them out. What was the conversation on those?
I think you're talking about the civil penalties,
Yeah, on page 20.
Civil penalties on page 20.
20, yes.
on 21.
And forgive me for using the word, Mr. Chairman, conversation. I hate that word. came out of the committees on these fines.
Representative Singh.
Thank you. And just you're on page 20 or 21?
Yes, 20 and 21, just to
Okay.
kind of, just.
These are the civil penalties.
Right. So the only conversation that really occurred was, everyone was comfortable with the $1,000, but the difference between the size of the facilities, we were thinking about those, smaller facilities that are operating on a shoestring budget. And so we came to the conclusion that having a different, almost category for those folks would be appropriate.
Follow-up,
Yes,
Mr.
Senator.
Chairman, thank you, sir. So when I look at this, I do not really see a distinction. I just see each day a facility fails to comply, but it doesn't say there's like 20 patients or 32 going up to 100 or whatever for the different penalties. Did I miss that?
So Senator Hutchings, on page 20, lines 10 and 11, it talks about critical access hospitals, which I believe is 25 beds or less. And then on the next page, all other facilities, which I
Gotcha.
would say is the remainder. So 25 beds or less, or
That's what I marked,
more
so
than.
thank you.
Thank you. Does that comport with your understanding of the bill?
Mr. Chairman, yes, that's correct.
Thank you. Further questions?
No, just have them sit tight.
Okay, thank you. Let's start with agencies first, and then we'll go to general public comment. Mr. Fuchs, welcome.
Good afternoon, Mr. Chairman, members of the committee. My name is Franz Fuchs, Deputy Director of the Wyoming Department of Health. Mr. Chairman, we don't have too many comments on this bill. We will be happy to work with the hospitals to develop rules to implement this as efficiently and effectively as possible. Other than that, we're happy to stand for any questions you might have.
Mr. Fuchs, this has obviously some obligations to the department besides rulemaking, as far as monitoring, et cetera, and then potentially assessing, I guess we're calling them, what do they call it, fines? Yeah, civil penalties, sorry, civil penalties. And I don't see an appropriation, I don't see it, so where would it be handled in your department? And do you have, do you have the staffing to accomplish this?
Mr. Chairman, we did a fiscal note on this with an administrative impact of approximately $17,000 a year, recognizing that our budget is, I don't think it's actually included on the LSO site, but we have I could provide you with the administrative impact. But given in the context of our entire budget, that's fairly low. We feel we could absorb the duties and responsibilities.
All right. Questions for Mr. Fuchs?
Thank
Senator
you,
Hutchins.
Mr. Chairman. Mr. Fuchs, I'm surprised. You guys don't seem to have a problem with it, and you're willing to run with it. That makes me happy. Thank you.
All right. Mr. Fuchs, do you monitor, or does the department use any of the CMS data data that is referenced in this bill? Thank you. Go ahead.
Mr. Chairman, we do not. We're tangentially aware, and I've looked at various hospital websites occasionally out of curiosity to see, what this looks like. But at the end of the day, we would try to reduce the burden on hospitals to the extent possible of conforming our requirements with the federal requirements and harmonizing with what's in the bill to the extent possible.
Okay, thank you. All right, thank you very much. Public testimony, come on up. I've got two people that have indicated they want to testify online, so we'll do the folks in the room. If you're interested, come on up, don't be shy. We're not going to wait all day, so come on up and provide your name and who you represent and your testimony, please.
Thank you, Mr. Chairman. My name is Patrick Neville. I'm the former Republican leader in the Colorado House. So I'm here, this is kind of free therapy for me. I'm a recovering elected official due to term limits. So this is the one good thing I got done in a very blue state. So thank you for taking the time. I would say, so I passed a similar policy in Colorado in 2022. So let me start back at President Trump, 45, started this process in 2019. And he created rules that required hospitals to basically do two things. Post a full file by CPT code of all their prices in machine-readable format, and then one of either of the two, post a shoppable services list or an estimates list. He started that in 20,
Just a moment. What was the second one? A shoppable or a
or an estimates, a price
estimates?
estimator
Okay,
tool.
estimates. Thank you.
So they're required to do the machine-readable file no matter what at the federal level. And to answer your previous question, that does include all the gross, standard, payer-specific charges. The key difference in this bill that Representative Singh is getting right, that I probably did wrong in Colorado, is I actually didn't codify it into state statute. And I would tell you that it was the administration's intent at the time to get prices in dollar amounts. What's happened over the first 3.5 years of the previous presidential administration is enforcement has been incredibly lacking. And then over the last 6 months of the last administration, they've actually rolled back the requirements. And they've done that through different guidance letters, different things like that. But what they've allowed is for prices to be posted in algorithms or a percentage. A lot of times that's a percentage of something that's not even a publicly available contract, so consumers can't actually know and shop. And so this bill would actually give Wyoming the ability to have those prices in dollars and cents, give Wyoming the ability to enforce those rules, and then the consumer themselves some protections. And you might hear that this might lead to frivolous lawsuits. I'll tell you, the bill that I passed in Colorado has been in effect since August of 2022, and there hasn't been there's been 2 lawsuits that I'm aware of, and they haven't even gone to, so over in 2.5 years, 2 lawsuits, they haven't even gone to fruition. So it hasn't led to a cottage industry of different lawsuits. What is actually happening is it's putting the consumer in the driver's seat. So we've actually had this. Patient X gets an estimate that it's going to be $1,000 for a procedure, and the hospital comes back and bills them for $70,000. The patient now has some leverage there to say, were you compliant? This was not the price that you posted previously. You're charging me something different. And typically, we hear back almost all the time that, oh, our mistake, billing error, you're correct, $1,000 out of pocket. So it's actually giving the consumer some leverage, which is a really powerful enforcement mechanism. And that's why in Colorado, it's actually led to some of the highest compliance rates in the nation. The issue, like I mentioned before, that we didn't do in Colorado is we didn't codify and specifically put in dollars and cents. So we had some tech aggregators that actually came together and actually developed some shopping tools. So in Colorado, you could go online and say, I want to get this price, and here's my insurance company. You could go shop insurance, buy your insurance and buy cash prices. And that was working really well until the previous administration kind of rolled that back. And now you just see an algorithm that you can't even understand. And it's also given consumers the ability to actually go out and shop, which is, it's what we want, it's what we need. It's a huge step to make a functional market in what's over 17% of our national economy is healthcare. It's a non-functioning market. And that's why we see things that are like elective procedures where you can actually go out and shop. They've gotten cheap as things, human race gets better at what they do, things get cheaper, better, faster, but we haven't seen that in traditional healthcare. This would go a long way to do that. And then I'll also mention, this is really good for businesses, because a lot of businesses, what they're doing is they're actually giving their employees incentives to say, hey, here's our insurance, but we're gonna self-insure. And if you can find a lower price out of our network, we'll share half of the savings with you and give it to you in the form of an HSA. And so the business wins, the employee wins. It's been really powerful, and it's been a big step to the creating a functional market in our economy, which we desperately need.
Okay, thank you. Senator Hutchings, questions? And Patrick, what was your last name?
Neville, sir, Neville.
Neville, sorry. Go ahead.
Mr. Chairman, thank you. Mr. Neville, out of Colorado, how many other states do you know of that have passed similar legislation?
There's quite a few. I would say Ohio just signed a bill into law on January 2nd, and that passed unanimously. Colorado, my bill was 99-1. I honestly think it was a fellow Republican that voted no, and it probably was a personality conflict more than a policy conflict, as we know that can happen. Oklahoma's passed the affirmative defense for the consumer. That was passed unanimously. Rhode Island passed a bill unanimously. It's a very popular issue that actually both sides of the aisle can come together. And when we do polling and stuff, and other people have done polling, we see it pulls at over 90%.
Thank you,
Follow-up,
Senator
sir.
Hutchins.
Is it possible you can get that information to us?
Absolutely.
Thank you so much. Let's see, what else? That's it.
I'll have on Colorado specifically, 2002, so this has been in effect 2+ years. I don't know when your laws go into effect, but ours would be July 1st. So 3 years in effect if it were essentially similar to ours. How many compliance issues have there been? I think you said there's been a very high compliance, but how many compliance failures?
Mr. Chairman, there still are compliance failures. One of the things that Colorado also did differently is instead of giving the health department enforcement authority, they made it a violation of a deceptive trade practice, which is actually a much more stiffer penalty. In Colorado, I think that's up to $1,000 fine per incident, and there's no like negotiation. I think this bill's done it more of a lighter touch. So the department gives them 30 days. They can actually kind of communicate. And when you have a state department doing that with a state hospital, you have more communication than you would at the federal level. So there have been some issues, but what we're seeing is as those people come through and as the consumers themselves are actually challenging the bills, you see the hospitals starting to say, okay, yes, we're going to go more and more into compliance, except for the fact that recently, because of the previous administration's guidance, now we're starting to see those algorithms in percentages be put in files instead of just prices, which seems like it'd be common sense, but that's what's happening.
Thank you. The non-compliance, is that, I mean, you're a state that has critical access hospitals in different communities. Seems like this is a bigger lift for administratively and maybe financially for smaller hospitals than large ones, and you have numerous large hospitals in your state. So any comment on how actually implementation went as far as rural versus, and I've already made a differentiation on the fines, which I think is actually problematic personally. If they have the same obligation, they should pay the same price. But so what about implementation, small versus large?
Mr. Chairman, I would tell you what I've seen is we actually gave the critical access hospitals a little more time to come into compliance, but what I've seen is the critical access care, the smaller hospitals, they're already worried about the fines from the federal government can be much, much larger. And so they're already worried about that. And so most of them have already come into compliance. What we're seeing is it's usually the largest systems in Colorado and then across the nation that are the ones that are not complying. And they should be the ones that are easiest to comply. But what we're seeing is that the smaller hospitals are easily coming into compliance. It's the larger, big system-owned hospitals that are not in compliance.
All right, thank you very much. If we get any further questions, I appreciate you being here.
Thank you.
Well, good luck with your recovery.
Thank you, Mr. Chairman.
All right, go ahead, Josh, Mr. Haynes.
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. So I think the first thing that I want to say on behalf of hospitals, and I will say I emailed the committee some information yesterday. I think I'll just cover those comments, and then I have some specific comments on the bill language itself. But I do want to be clear that hospitals are not opposed to transparency. But what I cannot stress enough is that because of the way this bill mirrors federal law, patients are not going to have any additional insight into their out-of-pocket responsibilities if you pass this. I encourage you, I provided links to the committee, but I encourage you all to go and look at your community hospitals and what's available to see, which is going to nearly mirror what is being asked of in this bill. I'd also say Wyoming hospitals really led some of the charge on transparency going back to 2012. So since that time, on the Hospital Association website, you could see the charge masters for all of the hospitals in Wyoming and shop based on that. Now, it's not nearly sophisticated as what's available today, but what I think needs to be very, very clear is that insurance companies are who determine a patient's out-of-pocket responsibility, which is what a patient wants to know when they go in for whatever service, what's my responsibility? And you have to talk to insurance companies about that. They set plan design, they set deductibles, they set copays that we end up having to collect, but the insurance company is the one that has the insight onto that side of what a patient's out-of-pocket responsibility is going to be. I guess I'd say, in case of cash prices, those are available. You can go if you're uninsured. There's a discounted cash price. Most hospitals have generous sliding fee scales that they provide to those patients, and that's available as part of this regulation. but was even available. For instance, the hospital I worked at, we took a lot of time and care to craft those policies. And so I guess what I would just say overall is that if we want to have a conversation about additional transparency, we're happy to have that. I'm happy to go anywhere and talk to people about what we can do to fill in gaps that you're not seeing. And so let's have that conversation. But this bill doesn't accomplish that. It does not give any greater information to patients than what they already have. Now, specific to the bill, on page 15, excuse me, it talks about reporting requirements and that every time a facility updates the list, they have to report it to the State Department of Health. In a lot of cases, these lists are being updated constantly. And so that reporting requirement is probably unmanageable for our hospitals as these are being done online and on a regular basis. Secondly, as it relates to the penalties, and not the fine specifically, but it prohibits, I think the language is that if you're found to be in material violation, that you can't collect and you can't bill. I'm not aware of any other situation where the State Department of Health would do something like that. And then secondly, material violation is not at all clear. So some clarity as to what would put us in material violation before we have to totally cease collecting money for services provided, I think would be needed going forward. So with that, I would stand for any questions.
Thank you, Josh. So I did not follow a link that you provided to any of the hospitals, but previous testimony was that the CMS regulations don't require the pricing, the dollars. Like I said, I didn't go to any of the links that you provided, so that's on me. But so is what's being provided, what you represent as being provided, is that only the CMS, or is that CMS plus what the hospitals are providing? Go ahead, Mr. Haynes.
Thank you, Mr. Chairman. So it is what CMS is requiring plus what we're willing to provide. So Cheyenne Regional, for example, Senator Hutchins, your local hospital, provides it in dollars. Your hospital, Mr. Chairman, also provides it in dollars, and a number of them do. So they're not required necessarily to do so, but in our review of our members, most of them provide the dollar amounts.
All right, so just to follow up on that, so is there a way to make this bill require the CMS standards plus the pricing, and that actually accomplishes the full spectrum of what this bill is trying to get to? Mr. Haynes, in your view, others can have other views, in your view.
Sure, Mr. Chairman, yes, if you wanted to delete all of the bill and require hospitals to put it in dollar amounts, if I'm following your question correctly, I don't think that would be an issue.
All right. Senator Hutchings, my apologies.
Mr. Chair, Mr. Hennis, you're saying you're already doing this, and the patient won't see anything different if you're already doing it. It's kind of weird. But what about codifying this into law? I think that's important. Not just say, hey, we're doing this already, we want to see it in statute.
Mr. Haynes.
Mr. Chairman, Senator Hutchings, it is in fact in law, it's in federal law, and we're regulated by CMS to do these things, and they do monitor compliance, and they do send out letters of notification when you've fallen out of compliance, and provide I want to say it's 30 days, maybe it's 45 days, to come back into compliance. So this is something we're held to, and there's consequences for not being in compliance.
Senator Hutchings, follow up.
So, for those of us who like state law over federal law, I think this is important to get it codified into state law that you'll be doing this as well. And then, and I'm going to move on to another question, and you can answer them however you like. You said there's a list on the Wyoming Association's website. I'm a patient. I would never go to the Wyoming Association website to look for prices. How would I know to go there?
Mr. Haynes, I guess that's one question. The second question is, where else is this information available?
Sure, Mr. Chairman, Senator Hutchings. So to your second question, we have periodically throughout the 13 or so years since it's been there done public communications and education out into the state to direct people to the website so that they can look at that.
Is it, so just to jump in here, is it accurate that most of these hospitals have it actually on their own websites as well? Mr. Haynes?
Oh, Mr. Chairman, yes, sir. Yeah, those charge masters, and they've been available. Like I said, it's not nearly as sophisticated a process as what is currently required and what we currently do, but it's something that our hospitals took initiative on more than a decade ago to provide some transparency. And to your comment again, Senator Hutchings, about codifying it into state law, what I would say is that if there are identified gaps and there are data elements that people want to know, I am happy to have those conversations and participate. What is it that patients aren't seeing now that they'd like to see? And we can do that. But this bill doesn't benefit patients because it doesn't give them anything extra.
Okay, thank you very much.
Let me see.
We had more people here, you'd get more questions, so I guess you're getting lucky. Let's go online. I see someone on the screen, and I can't read names on that screen, so I'm going to guess. Go ahead and introduce yourself and provide your testimony.
Hi, this is Linda Bent. Mr. Chair and members of the committee, my name is Linda Bent, and I'm representing Patient Rights Advocate, a nonprofit seeking price transparency in healthcare. We support this hospital pricing transparency bill because actual prices in healthcare are necessary to empower patients, employers, and all consumers to take control of their healthcare spend and be protected from overcharges. Our research found that only about 21% of hospitals nationwide are meeting every requirement of the federal price transparency rule, while most are actually posting pricing files. This non-compliance blocks tech companies from building tools to help consumers shop and leaves patients vulnerable to overcharges, surprise bills, and medical debt. Our research also shows that prices can vary by up to 10 times within the same hospital and by up to 31 times across hospitals in a region. When patients can see these prices, not estimates, upfront, they can become informed consumers to make the best decisions and protect themselves from overcharges. The Biden administration watered down and rolled back President Trump's price transparency rule by allowing hospitals to post estimates, formulas, and percentages instead of actual prices in dollars and cents. What good is a price list without prices? Would you ever see a restaurant menu with an estimate or a formula instead of a real price? Every day we hear from patients who trusted the estimate their hospital gave them, only to be stuck with an outrageous bill they couldn't foresee nor afford. Then when they couldn't pay, they get brought to court, have liens put on their homes, or have their wages garnished by the hospital. Without accountability and integrity in billing, hospitals can charge whatever they want. This bill is critically necessary to codify and enforce the original intent of President Trump's price transparency rule by requiring dollars and cents prices, so consumers can shop for the best quality of care at the prices they know they can afford. It will protect them from overcharges, give them remedy and recourse to fight a bill if it doesn't match the price, and ultimately it will lower the cost of healthcare for all Wyoming consumers. Thank you.
Thank you. Questions for Ms. Bent?
Job.
Questions? I guess I have a question. The price versus estimate. So if there's a price posted, does that somehow guarantee that's what the patient, that the maximum the patient would have to be responsible for if they had needed additional services or not?
So the way that the Biden administration rolled it back, they are now allowing hospitals to post an estimate, an average historical allowed amount in the machine readable file, which is not an actual price.
So my question again is, if you have to post an actual price and there's anything else, that's what you get no matter what services you would receive? Or is there the ability, if there's a complication in the procedure, whatever, can they actually add those additional fees in or not? Thank you.
So as I understand it, the patients, when they receive their bill, they can look at each CPT code and compare it to the CPT code in the machine readable file and use that to fight their bill.
Okay, thank you. I just say, I went to have breakfast at my favorite Sunday breakfast place this last weekend, and I've never looked at the menu before, but on the door when I walked in, it says every egg is an additional 25 cents. Just telling you right now.
Yeah.
Just telling you right now, things happen. But anyway, all right, thank you, Ms. Bent, I appreciate it.
Sir?
Go ahead, did you have a question?
Yes.
Please, Senator Hutchings has a question, Ms. Bent.
Okay.
Thank you, Mr. Chairman. Ms. Bent, just to kind of piggyback on what the chairman was asking, say for instance, I'm having my knee surgery and something, I know I'm paying 20,000 and something goes wrong. What happens there with the pricing? Something additional has happened, the doctor needs to do something different. How does that work?
Ms. Bent,
So we encourage our patients to look up the price and get an actual price in writing in advance. And then that way they can use that to fight if they are overcharged, if that makes sense. There will be there are price transparent surgical centers that post an all-in price where you know that you're not going to be charged more than that. Which we've seen it with plastic surgery and things that are truly shoppable. The surgery center or the hospital will agree on a price in advance. Did that answer your question?
Yeah, that's fine. Thank you.
thank you. Since you work on this maybe on a more national level, this bill is specific to hospitals. Has it been applied to any other healthcare facilities that are providing services?
No, this is only for hospitals.
I know the bill is, but has been applied elsewhere.
Oh, no, I don't believe there have been price transparency rules applied to other types of facilities yet.
Okay, all right, thank you. Do we have a Marnie Carey available?
Yes. Hi. Yes, hello, I'm Marnie Carey. Thank you so much for having me today. Good afternoon, Mr. Chairman. I am president of Power to the Patients, a national advocacy group that works on behalf of patients to help them know the price of their care up front. We are strongly in favor of this bill, and we are also strongly in favor of the hospital price transparency rule that went into effect in 2021, but as Mr. Neville pointed out, has foundered for lack of enforcement. With only 21% of the nation's hospitals following the federal rule, that means 4,000 hospitals are not. And yet only 17 hospitals in the country have been fined. HB 121 would codify and clarify the federal rule by requiring hospitals to post real dollars and cents prices, not estimates or percentages, and would put teeth in the law by allowing the Department of Health to enforce it. And it would allow recourse for patients to avoid collections if they were charged by hospitals who weren't in compliance or weren't posting accurate prices. Real prices and enforcement are, of course, necessary for patients to realize the full benefits of price transparency. But rather than give you a laundry list of the self-evident reasons why it's important for consumers to know prices in advance, I want to briefly share a story that illustrates a systemic problem that we have because we don't have price transparency. I want to briefly share the story of Nanette Hernandez, a single 46-year-old Cheyenne resident who works at a truck stop. She got COVID in 2021. She did not have insurance. She asked her boss for time off, and he didn't give it to her, so she quit her waitressing job, went to an urgent care, and they sent her to the hospital. After 3 days, she received a $32,000 bill. Now, 1/3 of Nanette's bill was for a drug called remdesivir. The drug's manufacturer has set the price of this drug for uninsured patients at $390 per vial. The hospital charged Ms. Hernandez $2,124 per vial, and that's over $10,000 because she had 5 vials. Also that year, the federal government reimbursed this hospital for all hospitals for their COVID-related care for uninsured patients. According to the hospital's audited financial statement, in this case, Cheyenne Regional Medical Center, that year the hospital got $15 million in federal relief funds. Nanette didn't get any of that benefit. Instead, she lost her apartment and had to move in with her mother. Now she works for $16 an hour, and the hospital has garnished 25% of her wages to pay off her bill at 7% interest. This shouldn't happen in our healthcare system, in our society, or in Wyoming. HB 121 would help hold hospitals accountable, expose these overcharges, usher in price competition, drive prices down and access up, and protect patients by offering recourse. I welcome your questions, and I thank you for this opportunity to testify today.
Thank you. Senator Hutchings has a question.
Thank you, Ms. Carey. Question on your testimony. Can you send that to us, to the committee?
You bet, I sure
Thank
can.
you. Thank you so much.
My pleasure.
And so my question would be, you use I wrote it down, so I hope it's accurate, avoid collections. So if a hospital is out of compliance with this, then they could, and a patient was in whatever that time frame is, a week, a day, whatever, and a patient receives services, they could avoid all collection for the services they rendered. Is that what I understood the testimony to be?
Yes, my understanding is that if a hospital is not posting its prices on the day that a patient receives care, that hospital cannot send the patient to debt collections for that bill. And that gives the patient a private right of action and recourse to say, because in the Colorado Supreme Court, they ruled that a hospital cannot be, or a patient cannot be held accountable to pay a price they could not know. So if the patient could not know the price on the day of their service, they can't be sent to collections.
So so thank you. If a patient came in under emergency circumstances, had no opportunity to see what the prices were, the hospital was out of compliance, the patient could make the case they don't have to pay for any services?
This hasn't been tested yet, but theoretically, one could go back and get the screenshot of the hospital's files will be monitored regularly. You could find out if the hospital was posting prices on the day of service, and if those prices did not align with the ultimate bill, that patient would likely have recourse, yes.
Thank you. Further questions? All right, thank you. Anyone else online? All right, anyone else in the room? Go ahead, Mr. Doherty.
Mr. Chairman, thank you. Senator Hutchings, appreciate the opportunity to appear. Jeff Doherty here on behalf of FGA today. Mr. Chairman, in light of the really fascinating testimony that preceded mine, I don't have much to add except a couple of quick things. I did a quick search of the various hospitals, the 28 hospitals that are in the state, and helpfully it looks like a lot of them are compliant in terms of A, having a website, and B, having it searchable. What I wasn't able to do is to determine if all 300 services were there in a digestible way. I'll tell you, I looked at sites like patientsright.org, who did a little bit deeper dive than me, and they indicate that some of the hospitals that I found as being compliant were not compliant because they believed that they were not posting all the required files. So, Mr. Chairman, I would tell you that I think this is a good bill, and this is a step in the right direction for the consumer, and I hope you will consider approving this bill.
Okay, thank you, Jeff. Questions? No. All right, thank you very much. All right, further testimony? I don't see any. So close public testimony. As we don't have a quorum, I do have 2 absentee votes, but I do not have a quorum to actually make a motion. We're unable to take any action on this bill. It will be noticed for that action on Friday at our noon meeting. We will have other bills up, but there will be no public testimony on this. It will be his consideration, excuse me, of the bill, and we'll take it up then. So I apologize to those that traveled here, those that participated online, but we're not going to be able to complete this action today. We'll take it up next week. I will also have 2 other bills up for next meeting, my apologies. It'll be on Friday at noon hour as well, and I'll have 2 other bills that we'll take up after we dispense with this one. So thank you. Representative, if you want to make any closing, I'll give you the opportunity. You want to make any closing comments? And then we'll just let you get back to your work.
Thank you, Mr. Chairman, members of the committee. So just in closing, this is a bill to protect the consumers of people of Wyoming. And this affected specifically folks in the city of Cheyenne, and I am inspired by their story. I do want to make sure that we get this right, and I don't want to somehow cripple our medical system that we have in the state. I understand that things are fragile, but at the same time, folks should be knowing what it is that they're going to be paying before they should have that opportunity to know exactly what it is that they're going to be paying for any sort of procedure. And so thank you for taking the time to hear this bill. I really do appreciate that.
Yep, thank you. So I have two questions. It was brought up about the out-of-pocket. Does anything in this bill actually help or give the consumer more access to what their out-of-pocket would be? Representative Singh.
Mr. Chairman, so that would be one of the available prices provided in the menu.
Okay, well, I guess if they're, I mean, it might be within the range, but I don't see how they would know what their insurer expects them to have as out of pocket. So just think about that, and we can talk about it offline. The second question I guess I would have is this, this compliance and the inability to collect for services rendered. If they're out of compliance, I think I heard at least two people say, if the hospital is out of compliance, then they would, and a patient receives services, they would be, the hospital be unable to collect for the services rendered. Is that accurate the way you understand and you want this bill to read?
To my understanding, yes.
Okay, thank you very much. Further questions? Senator Hutchings.
Yes, Mr. Chairman, I saw that a little different. The way I look at it, if a hospital's not in compliance and the patient receives services, then they cannot come in and, what is it? It was like the, go to collections with it. So they would still have to pay, but they couldn't go to collections to kind of harass them. That's kind of the way I saw it. And I don't know if that's what you heard or didn't hear from Mrs. Carey.
Okay, thank you.
Mr. Chairman?
Go ahead, Representative Singh.
I misspoke. The way that Senator Hutchings is describing it, that's what I intended here. I apologize.
So you agree, so the agreement, so there's an agreement between the two of you that you can't go to collections, but you can still collect for services rendered? Is that what I understand, Representative Singh?
Yes, Mr. Chairman.
Okay, all right, well, I'll have to read that a little more closely. Thank you. All right, nothing else? Thank you very much, Representative Singh. We will have this up Friday at noon. It'll be the first bill up for committee consideration. Thank you.